Thank you very much. So I'm Darshak Sanghavi from the Brookings Institution, and I'm going to pick up on some of the threads we've heard throughout a variety of the talks today and try to lay out a framework, at least the way I think we should all think about how we're trying to make positive change in healthcare today. So one of the things I'm always struck by is in the 1970s, if you were a child with leukemia, you had about a 90% chance of passing away. Very, very caring physicians, parents, even the patients themselves and the system work together so that approximately 25 to 30 years later, instead of 90% of those children dying, 90% of them were actually living. And why is that? Was it an amazing new chemotherapeutic agent? Was it new technology? The answer is none of the above. In fact, over that period of time, not a single new pharmaceutical agent was developed. Instead, it was taking and refining what was already known, managing side effects, and that's what led to that improvement. And I tell that story because in healthcare today, I think we have two general kinds of problems. The first are gaps in knowledge. So as you heard about, we have extremely sophisticated researchers that are doing cutting-edge work trying to figure out new cures, creating new pills that will cure cancer possibly someday. But on the other hand, we have issues of coordination, of simply applying what we already know. In other words, why aren't we doing better with what we already know? And that's really the opportunity we have when we talk about healthcare delivery reform and how do we then support that with payment reform. It's that type of problem. And there's a lot to that. And those can fall into many categories. I'll just mention two. The first is, as we mentioned, drug costs. We have seen that this is in adjusted 2012 dollars, that drug costs per month for the average patient with cancer have risen from $4,500 a month to $10,000 per month. A massive increase in the amount of money that insurers and ultimately patients may also have to bear because there are co-pays. And I've included a graphic there because in today's day and age, in one of the most highly industrialized countries today, 25% of people who have cancer will actually burn through all of their savings in order to help pay their responsibility for their care, even when they actually have insurance. Just think about that. So those people are really wiped out, not only by the biological reality of their disease, but by the economic reality as well. That's a little bit of the economic toll. The second is the quality issues. There are many, many extremely caring physicians out there, many, many extremely caring nurses and systems, and yet even so, 22%, that's 1 in 5 patients who have colon cancer, do not actually get the recommended care even when they interact with the healthcare system. For breast cancer, that's 15%. Think about that. Almost 1 or 2 in 10 women who have breast cancer also do not actually get recommended therapy. And remember, this is on top of some of the issues you've already heard from Brian and Bill, that many patients are actually misdiagnosed as well. So these are some of the challenges we're talking about dealing with when we talk about healthcare delivery reform and payment reform. This is stuff we already know. We don't need to go back to the lab and invest billions of dollars at NIH to figure this stuff out. We just need to do better with what we already know. So this is a broader issue. How do you get people to change? How exactly do you change systems to make them better? I'm going to start with an example. I'm a parent. I have 2 kids. I've had them in daycare. And some of you may know, daycare is a microcosm of all of your entire life. And I'll say that because in the 1970s, actually, some of you may be aware, Paul Krugman, the economist, looked at a daycare center in Washington, D.C., where they had a voucher system, and in that saw sort of the issues that arose with non-liquidity, and thinks about that with recessions and how to stimulate the economy. And that's been formative in his thinking about how he thinks about economics today. Similarly, in daycare settings, I want to call your attention to a study that took place in Haifa, Israel, some time ago. Parents... The daycare center had a problem. You know, when your kids are in daycare, you got to pick them up at a certain time. And as many professionals know, you're always rushing out of the house in the morning. You know, I'm a physician. I'm guilty of when my kids had a little bit of a fever, bolusing with ibuprofen as they go out the door, knowing that 6 to 8 hours later I get a call that the child had a fever, and I plan my day around that. On the other hand, at the back end, 5 o'clock rolls around, you can't be late. And this is the problem they had in Haifa. Parents were running late because they wanted to pick up their kids. And so they said, well, how can we use economics? How should we essentially use payment reform to change delivery reform? We want to make this better. And so they said, look, we'll use an economic incentive. If you're late picking up your child, you'll pay a penalty. And what do you think the result of that was? Twice the number of people started being late to pick up their kids. This is exactly the wrong outcome of what you wanted, because the way the incentives were designed failed entirely to cleave to the objective. Now, this is actually something which has been talked about by Daniel Pink in his work on motivation and drive. And this is a little cartoon taken from one of his talks. How is it that if you actually reward or create incentives that the system gets worse? Isn't that exactly the opposite of what economics incentive teaches us? And Daniel Pink draws our attention to one thing which I think is profoundly instructive when we talk about healthcare payment and delivery reform. And it goes like this. They took a bunch of students who were trying to learn math, and they gave them economic incentives. If you actually study and get a certain grade, you'll get paid a certain amount, right? So you get an economic bonus. And this was actually repeated in many, many other settings around the world. And if you actually did really, really well, you got a huge bonus. You got a lot of money. And they sort of repeated this study even in India, looking at workers as well. And what did they find? If you actually added an economic incentive to those individuals to see if they could learn a new skill, right? This is what we all do. We bribe your kids. You bribe doctors. You try to get them to do the right thing. What happened? In fact, money had exactly the opposite impact. It had a tremendously corrosive influence on physicians, learners' ability to actually improve behavior. And what grew out of that is this seminal observation, which I think should guide us when we talk about payment and delivery reform. It is that when you are doing things that are simple, making widgets, when you're kind of making sure you show up on time, manufacturing basic things, repetitive tasks, those kinds of economic incentives work very well. On the other hand, when you have complex tasks, trying to change your oncology system to take care of complicated problems, economic incentives actually have an opposite impact entirely. That is one reason why, in Pink's estimation, and again, what the data strongly shows is that there should be a three-pronged approach to improving and enhancing behavior when we think about how do we incentivize this. And I think that Pink actually has this quote, which I'll read, which is, you pay people just enough to take money off the table. And you let the rest of their natural impulse to do the right thing shine through. And I think this is sometimes seen as hopelessly naive. But I can tell you, when you look at the work of people like Barbara at New Mexico Cancer Center and many other physicians with whom we work, nurses, nurse practitioners, physical therapists, pharmacists, and others, they truly care a great deal about doing the best they can. And so there's this three-pronged approach, which is you want to focus on these things: autonomy, mastery, and purpose. Those are the things that actually internally drive people to continue to succeed. And in fact, these fall right into what we think of as clinical drivers. Autonomy, what is that? That's clinical judgment. You want to give providers the ability to do what they're trained to do without creating way too many rules, the mother may I approach, which is why it failed, which is why pay for performance is really roundly condemned by many, many providers, and they don't want to participate in value-based purchasing when it's on an individual physician level. Mastery, the other word for that in the clinical world is continuous improvement. It's what we all want to do. You get data, you get better and better, and that also is a virtuous cycle. And finally, purpose. Again, in our parlance, patient care. We feel driven by the morality, by the actual good work of taking care of patients. I think that's what shines through when you start being aware of that patient experience. What does this actually mean for payment reform? And I don't have all the answers. As you've seen, it's intensely frustrating. New Mexico Cancer Center, among many others, as an example, is doing the right thing in meeting and truly being patient-centered. And yet, despite all of the benefits that they have shown for patient care, are having a devil of a time finding an appropriate model to support them long-term to make this kind of work fulfilling and sustainable. But perhaps we can point to something that was in the news yesterday. I just want to point out how this can be helpful, which was, as was referred to earlier, we just got some preliminary data from United Healthcare's pilot programs. And what they did, to some extent, cleaves to Pink's formulation. What they did was they just paid for medications at cost. In the past, oncologists made almost all of their money as margin on giving pharmaceuticals. As you heard, that was really the buy and bill mentality. And instead, with United, they just paid for the drugs at cost. I can't emphasize this enough. In other words, they completely flipped the model of how oncologists make money on its head. You didn't just get paid for giving more drugs and expensive drugs. And instead, they gave them essentially a bundled payment that covered their hospitalization costs, their emergency room costs, supported in a lump sum right up front exactly the kind of work that Barbara is talking about and Laura are talking about, which is making sure you're patient-centered, taking those phone calls. And what did they find? 33% reduction in total healthcare costs. Almost all, and this is still in evolution, through reduced utilization of inpatient hospitalization services and emergency room care. Well, at the same time, the drug costs actually almost doubled. So in other words, you gave autonomy to the system. You let providers do the right thing. You let them use their clinical judgment. And you also created a virtuous cycle where you allowed them to do what was best for their practices.